Welcome, everyone. I want to thank you for joining. This is the February 24th webinar of Connecticut's SustiNet Patient-Centered Medical Home and Healthcare Quality and Provider Advisory Committees. I'm Ellen Andrews, and I co-chair the Medical Home Committee with Dr. Tori Westbrook, who's also on the line. Today we're hearing about patient-centered medical homes across the country. We're hearing from Lee Partridge. Lee is a Senior Health Policy Advisor at the National Partnership for Women and Families, where she specializes in performance measurement and quality improvement issues for lower-income individuals and families. From 1992 to 2003, she headed the health policy section of the American Public Human Services Association, which provides staff support for the National Association of State Medicaid Directors. From 1983 to 92, she directed the Medicaid program for the District of Columbia, and her background also includes 7 years on the staff of a U.S. Senator and 5 as Chief of Staff for the Health and Welfare Committee of the D.C. City Council, the district's equivalent of a state legislature. She has co-chaired several performance measurement committees of the National Quality Forum, and she's a member of the NCQA advisory panel considering measurement approaches for evaluating the patient-centered medical home, as well as a member of the American Academy of Pediatrics Medical Home Project Advisory Committee. She chairs the NCQA Medicaid Accreditation Advisory Committee. Welcome. Thank you, Lee, for joining us.
Thank you, Ellen, and it's nice to join you and Dr. Westbrook and all your panelists to talk about a subject that has consumed a considerable portion of my time and the time of some of my colleagues here at the partnership for, I guess, about 4 years now. Before I begin, let me just talk very briefly about the partnership itself. We are a national consumer advocacy organization. We've been in existence for over 30 years, and we focus particularly on issues that are relevant for women and families, such as pregnancy and health, well child care and care of seniors in our role as caregivers. We've been involved in the patient-centered medical home model discussion for some time, going way back to the initial meeting of a small group of stakeholders here in Washington when the joint principles were unveiled by the 4 professional societies. Since then, we have worked with consumer groups at both the national and state level, both in informal discussions and in actual formal surveys and focus groups, to try to get a better sense of what it is patients are most concerned about. And the issue that keeps surfacing all the time is better coordination of care, which is an issue that the patient-centered medical home model very nicely will address. So working with many of our friends in the consumer world, we developed a set of principles for what we hope would be embodied in any patient-centered medical home model. And we have also been tracking what's going on at the state level as these initiatives roll out across the country. And I'm going to talk this morning from some of the knowledge that we have gained as a result of that tracking project. Okay, next slide. One of the things that you see is that the initiatives for the patient-centered medical homes generally have pretty much the same model. The entity is a primary care provider, and it varies. That can be limited to a physician. It could be a physician. It could be a clinic. It could be a nurse practitioner. In Iowa, it's even a chiropractor. The emphasis in all of them is on improving the availability and quality of primary care and the coordination of patient care using a team approach. Most of the initiatives take the form of pilot or demonstration projects, but there are exceptions. Alabama has actually had what they call a patient-centered medical home program in place for their Medicaid maternal and child health population since the middle of about 2005. Illinois has an MCH program in place, and a number of states are moving either through legislation or on their own initiative, gubernatorial initiative, to some kind of pilot followed by statewide adoption. The target population is generally the chronically ill or medically complex patient, although again this isn't universal. the emphasis on the complex patient is motivated both by an opportunity to reduce cost as well as improving the experience of care. And I should mention here that all the health reform bills that we have been discussing over the past year, including the Senate bill that was adopted at the end of December, does have some federal funding to encourage Medicaid programs to use the medical home model. Generally, the PCMH initiatives assume that the practice is operating in a fee-for-service environment and that it participates in multiple insurance programs, although in some cases we're talking only about a Medicaid HMO, like Alabama. Next slide. In the next 3 slides, I talk a little bit from the perspective of several of the players as to what they hope to see in a patient-centered medical home. From the perspective of the state or the purchaser, which is the the employer usually, obviously better health care outcomes for patients. Second, reduce or at least limit the growth in the cost of care through things such as reducing hospital admissions, reducing unnecessary use of drugs, ER use, better preventive care. Third, enhance the coordination of care. And here you'll see varying emphasis on how broadly coordination of care is defined, because some will be quite explicit about involving not just coordinating within the practice itself and between practice and specialists or between practice and home health agency, but also specific links or at least informal agreements with other community care resources such as patient education programs, self-management training, social services networks. If you listened to the Vermont web presentation yesterday, I assume some of you anyway heard something about that in their blueprint program. A purchaser and the state also are looking for better patient satisfaction with both access and quality. And finally, and this is explicit in some and implicit in others, to attract and retain primary care providers in their community. Next slide. The provider objectives. Again, better healthcare outcomes, but greater satisfaction of your staff with their role is something that we hear about a fair amount when we talk to physicians or to community health centers. And I think it's probably evident in some of the conversations I'm sure you've already had, that there's a strengthening of teamwork when you've got most of your team members practicing to the limit of their license. And physicians will also report that they enjoy their job much more, that they have more time with their patients, they're more satisfied with their patients' outcomes, and they just like the world better. Obviously, this is explicit in the joint principles, but it's inherent in the assumptions that all of us have made. I think we recognize that primary care practices are generally underpaid, undervalued, and that we are asking them to do more under the patient-centered medical home program, and that should be recognized in the form of some additional revenue, usually some kind of monthly PMPM. But that can take other forms of recognition, like having the satisfaction of being a high scorer on something like the NCQI recognition tool at Tier 3, or public reporting that shows that you are a star performer, or sometimes a greater market share. Next slide. From the perspective of the patient, and this is a one-sentence distillation of our principles, it's a regular source of care for myself, for my spouse, for my child, for my aging parent, from a team that's accessible, knowledgeable, efficient, i.e. I can get an appointment and I don't have to wait for hours when I'm there. Compassionate, recognizes my needs in family situations. This particularly comes up in our conversations with caregivers who say, my doctor has proposed that I do such and such, but that's impossible because I have to be at my son's soccer game, or I have to get my mother to the doctor, or whatever. I can't schedule something on a regular basis. And also helps me as the patient maintain or improve my health and that of my family. And finally, of course, and not small for most of us these days, particularly as we look at dramatic increases in our health care premiums, we would like to keep our health care costs as low as possible. So those are the general objectives. Those are kind of the common characteristics. But once you get into looking at what's going on across the country with respect to certain, to the PCMH initiatives, there's a lot of variety. And I'll start with the payment mechanisms themselves. As I said, all the models recognize there will be some kind of additional or supplemental payment to the practice, but how much it will be and what form it will take is what varies significantly. Most of the ones that have been implemented, and a lot of the state, not a lot, but a number of the states are still in the planning process, and they often get to payment last in that process. But for those that are now in place, generally there's an additional per member per month payment of between $3 and $6. In Oklahoma, actually the top payment is now as high as $9. And that can depend on, and generally does, on the age of the patient. Child, adult, or senior is usually the split. Sometimes it turns on whether or not you have achieved a certain tier level in the NCQA recognition tool. For example, that $9 payment in Oklahoma is for a practice that has achieved level 3 recognition, and for the patient that's being cared for is a senior. Illinois is just a simple sort for age. North Carolina has a higher payment, but again, it's for seniors. There is often, in addition, a bonus for meeting certain performance measurement targets. And this is pretty common. The Illinois program has a specific list. They revise it each year, although they keep certain elements going for several years. And if you achieve, the practice achieves a level, a HEDIS performance measure score at the 50th percentile or above, you get a bonus for that year for that category. And as I recall, they now are up to 5 separate categories: asthma control, etc. And that would mean a potential of 5 additional payments to that practice and 0 if they miss. New York is talking of doing some kind of bonus system as well that's probably tied to NCQA tiering. Third kind of payment mechanism that shows up less often, but is certainly widely discussed, is the shared savings mechanism. Alabama has been doing this for several years. It is, in some ways, the trickiest to implement because you have to agree on what the base is, you have to agree on what the savings were, then you have to attribute them back to the practice in some fashion, and then decide what the split will be. As I say, Alabama has been doing it for some time, and they have a split between the state Medicaid program and the participating practices. In addition, and I'll talk about this a little bit more when I talk about transitions in a minute, many of the projects, whether they're multi-payer projects or state-only projects or a combination, have assumed that there will be significant upfront financial support. That is most commonly coming up in connection with some assistance in the use of information technology, and it could be either for the acquisition of equipment and training by the practice, or in some cases it means this practice will be plugged in to a state system that will act, or a health plan system that will allow the practice to access certain data about their patients and manage their care more effectively. The use of quality measures comes up most often in connection with bonuses, some of the common ones here are, as I said, reduction in emergency room use, reduction in inpatient admissions, reduction in use of brand name drugs. That was a big saver in the North Carolina patient-centered medical home program in its early years, and also for meeting certain preventive care targets. And I've seen that one coming up more frequently now at the state level. There will be one or two things with respect to child health in particular. It's fairly common to see something that either says successfully completed a certain regimen of comprehensive well child visits or has improved access to oral health. Another commonly used quality measure is the score on patient experience surveys, although this one, frankly, doesn't work very well yet with the medical home model on an individual basis. It's more likely to be used generically, and then you look at that practice and see how well they did. I'm thinking in particular here of 3 experiments that were undertaken in 3 major cities of using the CAPS survey tool at the physician and group level, and then reporting out the data on a practice-specific basis. If you were then attempting to evaluate the quality of performance of the practice that was the medical home, you could identify those practices and correlate them with that data. But to the best of my knowledge, nobody is really doing that in a sophisticated public way as yet. And finally, as I've mentioned, the HEDIS scores are used in the bonus programs and the standard set of HEDIS clinical measures. Characteristics around payment, qualification. Next slide, please. Here again, a lot of variety, and as the programs, as I see more mature planning processes take hold, I'm beginning to see more sophistication and variety in this set as well. One common one, sometimes actually embodied in the legislation, is that the practice has to be recognized using the NCQA PCC PCMH tool. Either as a threshold requirement, you can't even be considered unless you qualify, or as a condition if you participate within X period of time, usually a year, or you must achieve recognition at the Tier 1 level. And the Tier 1 level recognition is not that big a hurdle. The principal characteristic is that you have some capacity to generate a patient registry and demonstrate you manage and coordinate your patient's care, and you have a team approach. So for most states, there's a feeling that that isn't a significant barrier. However, some states decide that they're not going to use the NCQA tool or tie themselves to the NCQA standards, that they which isn't unusual, we all are different, that they will do their own. And probably the most mature example of that at the moment is the regulations that were adopted by the state of Minnesota for what they call health homes, which is their PCMH, at the end of November. And they have a very specific set of requirements, quite detailed set of requirements. And some of them are the same things that you look for in the NC2QA set of standards, but they go beyond to require things such as participation in learning collaboratives, providing the state with certain performance information. That's fairly common, by the way. Install and use certain electronic IT systems, involve patients, and this is particularly strong in the Minnesota regs, involve your patients in practice governance and practice improvement activities. And Minnesota will require an annual recertification process. And if you fail to meet the standards at the end of your second year, you will not be accredited for the third year. Next slide. We've also been learning something about the transitioning process itself. As I say, some of these programs have been in place for a while. All of them keep learning and tweaking, and we are seeing certain common things, and we are seeing certain things that are quite different. The most common is this requirement around some sort of information technology capacity, boosted now by the dollars that are available under the Federal High Tech Act, particularly for Medicaid practices. That is, 30% of your practice is Medicaid or uninsured patients. You can qualify for up to $65,000 over a 5-year period for assistance in the acquisition and training on an IT system. And there's a lower threshold. I'm assuming these thresholds, by the way, are in regulations that are out for public comment. I'm assuming they won't change. But there's a lower threshold for pediatricians, 20%. The opportunities to participate in learning collaboratives increasingly seems to be a popular element. I think people who've had that experience find them very useful. They share that information with other states and other practice leadership, and they put them in place. The same is true of establishing or locating appropriate patient education or self-management support programs, like the Vermont Blueprint, like the self-management training programs that the National Council on Aging is sponsoring across the country. Louisiana is doing something like this, and North Carolina, of course, has a quite different model, which I'll discuss a tiny bit at the end, which involves very heavy collaboration with a set of community networks. And finally, the transitioning process does require that you have some capacity to share data electronically, including putting in place special agreements with regard to privacy and security. And here the vehicle most commonly involved is a state health information exchange, or sometimes a regional health information exchange. I would say one of the issues that crops up often is that some of the data agreements themselves between a medical home model and others, or medical or practice and your Department of Health, can take time, and that has often proved to be something of a stumbling block in actual implementation. Next slide. I wanted to close this morning with a couple of what I call recent developments and news from your neighbors, with a special emphasis on Connecticut, because New England has always been in the forefront on a lot of health improvement activities, and no exception. Vermont has been working with the Federal Department of Health and Human Services to bring Medicare in as a partner in his project. I don't know whether they talked to you about that yesterday. I do not know how far they've actually progressed. They may have an agreement just about in place. I haven't seen it made public yet. But part of the concept here is that all the patients enrolled in the practice benefit from the transition to PCMH, and that Medicare should be a player. What one of my colleagues calls the no free ride rule. And now Medicare, in the form of the Department of Health and Human Services, is agreeing to do that. New York is using their a stimulus money, their high-tech money, as an incentive to encourage the adoption of the patient-centered medical home in the Medicaid program in the state. And they also last year won support from their state legislature to waive certain antitrust barriers in state law that will permit more collaboration, including linking a network of community health centers in upstate New York in a PCMH framework. Massachusetts just released its design and implementation framework for PCMH, and I don't know, Ellen, whether or not you all have had a chance to look at this. If you haven't, it's tremendous. I think it's very interesting. I mean, they pull together a multi-stakeholder statewide committee similar to what you're doing, and they spent quite a bit of time on all of the characteristics and certification requirements and so on. And just briefly, some of the highlights. They decided they're recommending their initial focus be on adults with diabetes and children with ADHD or asthma. And they start with an initial group of practices, but the expectation is that this is not, we're doing some testing of a pilot or demo. This is the beginning of a long-term process of putting in place a permanent improvement in care. They assume also that it's going to function within not just a fee-for-service, but an HMO and payment environment, because, of course, Massachusetts has a significant HMO presence. They assume they're also going to put in significant money up front, that there will be some kind of PMPM or supplemental revenue for accredited practices, and that there will be a shared savings. But the details on their payment mechanism aren't spelled out, and as I say, that's not unusual. That often comes toward the very end. Interestingly, they considered but didn't endorse the NCQA recognition tool, and they place a very major emphasis on consumer engagement, an area that they feel has not been given enough attention in other PCMH initiatives across the United States, and they created a special work group to develop detailed recommendations around both how do you reach the patient, him or herself, help her appreciate what a PCMH is, how she should work with it, and also help the practice and the community support that practice. Finally, North Carolina, one of my favorite programs. It's such an interesting and different model. North Carolina is a state that has no managed care, and yet they have a strong commitment to improving the quality of care of not just their Medicaid beneficiaries, but all their residents. So a number of the physicians collaborated to create something called the Carolina Care Access. It's morphed into a network of what they call area community care networks. There are 14 of them now, I believe, across the state. And they are paid a PMPM just like a practice is paid a PMPM, approximately $3 a month, to provide care coordination resources and access to community health supplemental resources, plus data sharing and some general support to those practices. And particularly in the rural areas, if you talk to some of the physicians in North Carolina, they just love it. Most significant for North Carolina, they've been trying for some time to bring Medicare into that network because they have a significant number of dual eligibles. And they just won approval last month from DHHS to do this, and even more interestingly, to share the savings realized between the federal, state, and practices. So the feds are definitely in the game. Finally, some thoughts from the front line. Last slide. Change is hard. I'm sure you've heard this. Long sustained leadership is critical. Don't overpromise. Change takes time. It takes investment, ongoing and upfront. But doctors love it, patients love it, and some of the early research results suggest it also does save money while improving access and quality to care. We think it's terrific. I hope this has been helpful, and thank you for your attention.
Well, thank you, Lee. That was great. I'm going to start while others are coming in with questions. I'm interested in I really like the emphasis in Massachusetts, especially on the patient experience, because we say it's a patient-centered medical home, but that kind of gets lost very quickly. But you said that it's not working, the patient experience surveys, to use that as a performance measure. Can you talk more about that and what's being done?
The recognized standard tool, the so-called CAPS, the community, I forget what the acronym stands for, is the one that would be most obvious to use would be the group and clinician survey tool. That is not very widely used because it's very expensive.
Oh.
You're asking an individual practice, or you're asking an insurer to fund pulling a sample and mailing it out to your patients, and then getting the responses back, tabulating them, et cetera, et cetera. And people, therefore, are very reluctant to use it. The experiments that I mentioned are using an all-payer approach. And in this case, it was 3 health plans usually, pooling their resources, saying, we'll pull the sample from the practice's entire caseload. Doesn't make any difference whether they're paid by Aetna or Cigna or the Blues or Medicaid. And we'll just draw a picture of that practice and how it functions in the view of the patients they serve. And that's the one that probably has the most promise of something that you could use as a tool to evaluate the success of the PCMH itself. But as I say, it would be a two-step process of matching the PCMH participating practice with that data,
now,
unless every practice in the state was a PCMH.
Yeah. Now, the NCQA accreditation requires that you track somehow patient satisfaction. Is that just not being used, or it's just sort of a process thing? Are you tracking it, or just does a complaint line work enough? So is that not a tool to use, or not so much? The NCQA recognition tool doesn't actually have formal performance measures attached to it the way their plan accreditation tool does. What they look for is that the plan does something, and even that, as I recall, it's an element, but it's not a mandatory element in the tool. Incidentally, that recognition tool is being reviewed, and the advisory panel starts our discussions on the 22nd of March. So if you all have suggestions as to how you'd like to see it changed or tweaked, just do log on to the NCQA website. You'll see a little box there
and use that and send them in,
Oh,
because
I'm
we
sorry
would
you
be
told
delighted.
us about that. Um, Jamie Sterling has a question. Sounds like most PCMHs have a central payer, either an insurer or the state. How can employers contract directly with the medical home system via their self-funded plan?
No reason why you couldn't say, we are going to, just as a health plan would, you'd adopt whatever you want to use as your criteria for participating, and offer whatever financial incentives you wanted to. Usually employers use somebody to administer their self-insured programs, and they would, and that entity would do it for you.
Okay. Are there any that are actually trying to measure care coordination? I'm guessing that
I'm
laughter
sure
is
there.
no.
I'm sure. I'm sure there are people who are trying very hard, and there are lots of us who are trying very hard to determine what would be good measures of care coordination, ones that would be the kind that would meet everybody's criteria for a commonly used measure. There are some care coordination measures going through the National Quality Forum process right now, but there aren't a lot.
Okay. Well, are there any states, you've mentioned some, sounds like Minnesota, Massachusetts, that you think are ones that we should really look for? I mean, this committee needs to come up with draft legislation and a plan for the state. Are there any that you think we should really be looking at?
I would certainly look at Minnesota's regulations. I'd look at Massachusetts' framework more because I think it's a thoughtful, it's about 12 pages, and I think it's a thoughtful discussion of some of the options and goals. I would certainly look at Oklahoma because they're functioning in an environment that's not managed care.
Mm-hmm.
It's a PCCM,
Mm-hmm.
and you have that in your state. I'm sure the state leadership there would be happy to talk to you about their experience. It's reasonably new. They put this in place a year ago. But Dr. Lynn Mitchell is their Medicaid director, and I'm sure she'd be delighted to talk to you about what they found and why they went from what they had been doing before to the PCMH model. You've talked to Vermont, so you have some idea about the involvement of your community and some of the self-management and care, education efforts, and you've talked to southeastern Pennsylvania, so you've certainly heard from your practices about some of the transition issues and the excitement, I hope, at least some of the
We heard about state employees getting hugs. It was wonderful yesterday.
Yeah, yeah. The principal concern for most of the people in those practices is, can we keep it going? Because it's a demo.
Mm-hmm.
It's funded for 3 years. So there's a lot of concern about how you can demonstrate down the road that it is preferred and we should sustain it. Those are the ones that and North Carolina, again, because there's a mature program, it's such a different model. It might be an interesting thing to look at from the perspective of a demonstration project around your dual eligible population.
Mm-hmm.
I don't know how big that is in Connecticut. Probably not all that big.
About 60,000, I think.
Yeah, you're on the whole, I think you've still got a state that's a little younger.
Mm-hmm.
And so probably your younger adults and your maternal and child health population more significant. But I will be happy to share with you, so you can share with your committee, some of the websites, and also we will be updating our tracking log in another couple of weeks, and I'll send that on, which has a lot of state-by-state data in it.
That'd be great, and we will post it to the SustiNet site as well so that it can go out to other committees as well. Tori, I don't know. Oh, sorry. Go ahead.
To say, one of the nice things is that you keep learning as you talk to people, and we're all learning together. It's a very collaborative and pleasant world.
That's great. Yeah, we're hearing a lot of energy from other places, and everybody says how they're going to help us, even though they are more busy than anyone I know. It's been really nice. Tori, I don't know if you have something you'd like to say, or maybe we lost Tori.
No, I'm here.
Okay.
I agree. It's been a great discussion, and it's wonderful having all this perspective from different states as we try to shape our state's perspective.
He's not going to be here Sunday to take it out. He's going to come in
Right.
Sunday.
So I think I want to thank you, Lee, very, very much.
You're welcome.
This will be up online, and the slides are already online on our webinar page at cthealthpolicy.org for anybody who's looking for them. And we will be bothering you often. Thank you, Lee.
Anytime. It's a delight. Thanks very much.